She does endoscopy, general surgery, everything from breast surgery to gallbladders, wound care, and cosmetic Botox. Please join me in welcoming Dr. Sambo to the platform.
Hello. Greetings from the tropical oasis of West Texas. I have with me Dr. Roach and Dr. Moses. And first, I just want to ask them to introduce themselves and their training and how they got here. So, Dr. Roach.
My name is D. Roach, and I'm a family practitioner in Colorado City, Texas, which is a very small rural farming community in West Texas. I did my undergraduate work at Texas A&M. After that, went to medical school also at Texas A&M, and did my postgraduate training residency program in Amarillo, the Texas Tech Health Sciences Center. After completion of my training, I actually moved to Colorado City and have been there ever since.
Dr. Moses?
Yes, I'm Dr. Lufkin Moses, general surgeon here in Sweetwater, Texas, about 10,000 people. I went to undergrad in Memphis, Tennessee, Memphis State, and then went to Kirksville, Missouri for medical school. Came out and practiced for 14 years, family practice and delivering babies. And I went back to general surgery in Fort Worth and came here and then been here ever since.
And when you guys say been here ever since, you've been practicing here for how long?
Too long. Since 76.
For you?
I've been in practice 37 years now.
So quite a bit of rural experience. So the first question I'm going to ask, because it's a popular question, what were some of the unique challenges that you found in rural practice during COVID? Yeah.
I think the biggest challenge was just simply limitation of resources in rural communities, not just physical resources, but more importantly, human resources. We had extraordinary difficulties even getting respiratory therapists to work for us, and found ourselves to be challenged with that regard. Nursing staff, similarly, we were having difficulty, obviously, with a lot of patients, large census for our small community hospital, difficult time covering our nursing schedule. And of course, physical resources, masks, gowns, gloves, all the personal protective equipment. Initially, we had quite a bit of difficulty procuring those items as well. So I would say the biggest challenge was just resources in general.
And how big is the hospital that you work in?
We're licensed for 25 beds.
Dr. Moses, do you know what we're licensed for?
It's 50 or 52 beds here in Sweetwater.
Okay. What do you think was the most challenging aspect of doing general surgery here in a rural setting during COVID?
Well, the worst part is you got to think before you do surgery at that time, because in our small area, if you have a complication or if it's a critical patient, of course, nobody, but it's hard getting somebody transferred. Everybody knows that. So we had to think, can we do it? Can we take care of them no matter what?
And I know we had talked about this before the camera came on, but a lot of the physicians in our group work at academic centers. So, pardon me. Can you tell them what difficulties we face when trying to transfer a patient?
Well, first of all, most everybody has hospitalists now. And then you got to go through the hospitalist before you can get to the surgeon. And then they have to work together, the surgeon there and the hospitalist. So sometimes if you're lucky, it's an hour or two. If you're not, it's a day or two. It's pretty complicated. Yep. we couldn't do the surgery here.
From a primary care standpoint, our greatest challenge, of course, was bed availability with the receiving hospitals. And it became such an incredible problem during COVID. We were actually begging for beds out of state just to get the more critically ill patients transferred away. And I'm not sure there's actually a bedding availability or more of a staffing shortage, probably a combination of both. But consequently, we ended up keeping people in our facility far more acutely ill than what we were prepared to do.
And, you know, one thing we talked about is sometimes it can feel kind of frustrating getting patients transferred, because I know that the receiving facilities are stressed and overloaded and, you know, they're busy, but when we are transferring a patient, it's not because we don't want to do the work, it's because we are like physically incapable of taking care of them at our facility. And I think sometimes there's a disconnect in understanding exactly what we have available to us and what we can actually do. I know that during COVID, like getting IR drainage, for example, was something that just was not going to happen. And I know Dr. Moses, that's kind of ties into the, so when you're stuck with a patient that desperately needs a procedure that you can't get done, what are some things that you've done to get through that?
Well, on most of the surgeries, we still, you know, we stabilize them. If we had to do surgery, we'd do it. And if they had some type of cardiac or renal problem, you know, over time, you know, you're going to get them out somewhere. But we never not took care of somebody. It was just, you do what you have to do. That's all I can say about it.
Yeah, I know there was times that we were trying to do some ultrasound guided drainage or taking them for laparoscopic drainage, and I think we just had time figuring it out. So outside of COVID, what are some challenges that you think are specifically unique to our setting?
Well, once again, resources, I think, is probably the greatest challenge that we have. Mostly human resources. The pool from which we have to choose our skilled employees is actually very shallow, and it's very difficult to recruit people to a rural community unless you grew up or comfortable with that area. But people from larger settings and urban areas, they just really don't care to live in a smaller rural community. Respiratory therapists, lab technicians, x-ray technicians, mid-level practitioners, physicians, nursing staff, it doesn't matter. Everybody, it's very challenging to recruit those skilled positions to a rural community. And once we get them there, it's even harder to retain them.
Yeah.
Yeah, and we were lucky. Our surgery crew are from here. Their family was from here. We had plenty of surgery crew. So it was just the complication of the patient, whether we could do it or not. And of course, on the other part, on the floor staff, well, I mean, we were lucky too with the state and federal government sending their employees, but it was still hard. But we were able to manage. We were really lucky, I think. It's still, the worst part was transferring somebody. That was, to me, and always has been, getting them to a tertiary center.
Yeah. So kind of the meat and potatoes, and I think what everybody wants to hear are about interesting, difficult cases that you guys have experienced in your, I don't want to call you old, but in your wealth of time here. So the first thing I wrote down was trauma, because I know that a lot of times the first trauma you get comes in. So I ask anything stick out to you, something that was crazy that you had to deal with, and what did you do, and what happened?
So actually, we were briefly talking about this earlier. This is a fairly recent circumstance that we dealt with at our hospital. We live on the interstate and state park with the lake, so we actually get quite a bit of trauma to our facility, believe it or not. This instance was a 12-year-old who was involved in a ski jet accident and sustained a mid-femoral fracture, expansile hematoma. Our EMS was on scene. They tried to do a scene flight with our air ambulance service that's available to us. Because of technical problems, they weren't able to land on scene, so they ended up transporting the patient from the lake to the emergency department. The helicopter landed on the helipad, but she was obviously in shock and not doing well at all. Precipitous blood pressure issues, and of course this expansile hematoma. We actually resuscitated her in the back of the ambulance, took her to the helicopter for transfer. Unfortunately, the helicopter didn't have blood available, so we actually had to take blood from our blood bank and give to the helicopter service just to get her transferred in some semblance of stable condition.
I think, and this is something that I don't think a lot of people realize, is how much trouble we have with flying.
It's terrible.
There is almost always something.
It's usually the weather.
Weather.
It is the weather or the mechanical issues, or we just reviewed a case where we had a polytrauma patient and they showed up and then the pilot was like, I'm out of hours. We're like, why did you come? You just came here to tell us you can't fly the patient. But the flying is difficult. And sometimes you're kind of stuck with them. Like you call for that transfer, but then you still have them for quite a bit of time.
Weather does seem to impede our
And when they
ability to
say
transfer.
weather, like you look outside and it looks like this and you're like, what weather?
And one of the worst, Sweetwater's right on the interstate, just like Colorado City. And we had a semi truck and then a van with 12 people in it went under it,
Oh, man.
fell asleep. And they brought them all in, and most of them were head traumas. Their ankles were in 4 or 5 different pieces, their femurs. Most of it was all bony. And trying to get them out of here, 12 people, was a nightmare.
Yeah.
That was one of the worst.
When I was in North Carolina, that was a little tiny town, only 2,500, but there was a prison nearby and they had a prison riot. So that was fun. They actually had like a special page out for like a special code specifically for prison riots. And had to deal with the people coming in for that. They like split them between the 2 closest hospitals.
One of the more challenging parts of managing trauma in a rural community is being able to maintain a state of preparedness. The trauma we see is just as bad as you see in a major trauma center. We just see it so less frequently, and so maintaining that level of preparedness has always been a challenge, where it be through educating staff or experience in the emergency department, or again, I keep on talking about resources, but it's probably one of the biggest issues that we have in small communities. Another instance where we had resource issues, recently a stab wound to the chest came to the emergency department. Our respiratory therapist was 25 miles away on call. So we, of course, put the chest tube in the patient and looked around, and nobody in the room knew how to hook up a quarterback.
Oh my God.
Nobody in the room knew how.
That's good.
That's a real story.
We had one recently here where they had tamponade and nobody had any idea where cardiocentesis equipment was. So
Same thing, same situation, same patient. Nobody could find the kit to put the central line in. It took about 10 minutes just
Yeah.
to find it before we could finally put it in.
What's the other equipment that we can, the Blakemore? I think that's a given at any hospital. Nobody knows where it is. Half the people don't know what it is. You get it, it's like inflated. There's nothing to deflate it with, nothing to attach it to. You're just handed this thing. What about you had that spleen case?
Yeah, I mean, we get everything too. Kid from Abilene, Texas, rolled his car over there, and he didn't tell his family, so he walked from wherever he was to the neighbor's house. They took him to his dad's house. He didn't go to the emergency room in Abilene or anywhere. Took his dad's car over here in Sweetwater. He rolls it.
I'm sorry.
Second spleen injury, but they didn't tell us about that. And we took him to surgery. He probably would have had more information, or we would, if somebody had heart. But took his spleen, that didn't save him. He was bleeding elsewhere. His demise, you know. Of course, the family, they didn't want an autopsy. They didn't want anything. Trouble with him, but that's the first time they tell me after the first surgery, oh yeah, he rolled it twice, 2 different vehicles.
In 24 hours.
Yeah.
Do you think that he was bleeding from his spleen from the first accident?
Well, I don't know what was coming off of that aorta or something clamped down, and then something we missed somewhere because, well, he just, that ischemic process just makes it, everything's not pouring out immediately. And there's no telling from under the liver or wherever the aorta or the kidney. So, yeah, really unusual things that happen everywhere.
Yeah, I thought you were going to say something.
I was just going to mention, not necessarily a trauma issue, but there have been some other circumstances where you really feel pretty helpless and hopeless. Earlier in my career, I did quite a bit of obstetrics. And I remember on a very cold, icy winter day, the lady came to our emergency department. She was like gravid at 12.
Oh my God.
And actually having a septic abortion. She was febrile, in septic shock basically. And because of the weather, we were not able to actually transfer her to a different facility due to limitations of travel. Even the highways were iced down, so we actually had to take her to the OR and do a DNC under those circumstances.
You speak just a
Fluids.
little louder.
Yeah, fluids, antibiotics, pressures,
Oh my goodness.
and she actually survived.
Yeah, I feel like one of the things that I love about this job is the kind of like MacGyver that we do, it's every day is different, and the challenges kind of, when you go in there and you're just kind of trying to figure it out, it feels uniquely special that you're just kind of figuring out. Sometimes, I mean, obviously you can talk to Doc. I'm a giant stress ball running around. I haven't hit the level of comfort that he has, but it is a good feeling just kind of trying to figure it out and making it work. And when it works, you feel really great about it. But there are days that you definitely feel like you're just beating your head against the wall.
There's those hard cases, and of course, growing up on a farm, and me and my sister, we're doing autopsies on pigs, dogs, cats. Nothing's ever bothered us our whole life.
At what age were you starting these autopsies?
We were in grade school, and you had those real kits, the real doctor kits then that had a knife, had a stethoscope, It had the microscope.
I'm gonna try to figure out how to not be a bush.
It was in a little brown case. I can still remember it. But we cut open every animal we could get a hold
I mean, were your parents worried by this behavior at all?
of. No.
I would be
I
concerned.
mean, we're
if I-
farmers.
Like, this is normal farm behavior.
Yeah, we just have to check it every.
If I found my children cutting open the livestock, I would be concerned. That's all I'm saying.
So really don't have the fear of that part. The fear is, well, you don't have the equipment, you know, it's not trained to put the aorta back or the brain.
Sorry, guys. I kept becoming a bush.
I noticed.
It was distracting. I couldn't figure out where to go to not be a bush. So now I'm not a bush.
You're okay.
So yeah, you were saying, was growing up on the farm when you realized that you wanted to be a surgeon?
No, after a hot summer in Missouri, and I baled 3,000 bales, I said, there's got to be something else. I can't do this.
So the choices were baling hay or rural surgeon?
Yeah, that was it.
Now I'm blurry. This thing doesn't like me at all. How did you know you wanted to do medicine?
Almost a similar story. I grew up also in a very small West Texas town and very involved in agriculture, mostly farming and ranching, and developed a real love for animals. And initially I thought I might be one veterinarian at some point. But once I got into school, so the pathways just sort of led me to medicine and loved it ever since.
Being told to stop moving around.
Neither do you.
Me, I'm fidgety, sorry. So what about, you guys have both done OB as well. So tell me about that. Did you expect to do that? Was that just kind of tied into the rural lifestyle?
Well, that was one of the reasons I left family OB, is because every time I'd call the city, Abilene or Lubbock or whatever, they'd always say, well, you've got a surgeon around there somewhere to do that appendix or to do that C-section. Because I had not trained in that on doing C-sections. And so that's one of the reasons I went back to general surgery.
It made you want to do more surgery, doing C-sections?
Yeah. And the other thing, everything that needed surgery in a small town, then the surgeons were coming and going. And said that I just wanted to learn to do it no matter what. So went back, surgery residency.
Did you have any like crazy OB experiences, either one of you?
Oh, my first year, I nearly gave it up. I had everything, complications you could have.
Really?
One of them came out with half their arm missing.
What?
Had a
Wait, where
placenta creta
where
right
was
here in
the Where
Sweetwater,
was that half arm?
because they were, the mother had been on drugs.
Oh,
I had a prolapse of everything you could think of. And, but every OB complication, that I thought it was me, you know, it didn't have anything to do with the placenta creta or whatever. And so that was like 7 or 8 OBs that first year. I should have given up then.
how about you?
When I started practicing medicine 37 years ago, pretty much everybody doing primary care in rural areas was sort of expected to do obstetrics. And so while in training, I tried to do a little bit of extra preparation for that, not knowing that there's no way to prepare for what's going to happen here in real world. The worst obstetrical experience I remember was very similar to his placenta accreta that ended up turning into cesarean hysterectomy, and what a mess.
Yeah.
What a mess. Scary stuff.
I know we have gone in together a couple times here on some bleeding that wouldn't stop. And once I was with you when you had to take the uterus out.
It happened. It's too many vessels down there. But it's just being prepared for it. That's the thing I think that scares a lot of people away from small communities, or not having 2 or 3 surgeons together and all that, because those critical things are gonna happen. And you just gotta step back and put pressure on it. And the very first thing I remember when I was in internship, surgeon way back then, he was doing a laparoscopic tubal and hit the ovarian vessel. And he took my finger, he made a hole, put my finger in there, hold that while I go scrub so we can cut her open.
Okay.
He came back in, did a midline and went in there and tied it off. But
I think one thing that we should acknowledge that maybe some of the surgeons working at the bigger centers and in cities may not recognize is when we talk about these experiences in these cases and where things don't go great, a unique problem we face is these small communities. And these, if a person has a bad outcome or a not perfect outcome, it's a very personal, and like they have 17 family members that all live here and that all know you, and you know it's very hard. You don't just, you're not in a town of 1 million people where you know you can be anonymous. Everybody knows who you are, and then you know they'll start talking. And
Small towns, rural doctors live in a fishbowl.
yes, that's what I was getting.
Everything you do, everything you see, everything you say is public knowledge, or made to be public knowledge.
Yes. And let's say you have a complication, it is magnified
Totally.
because it's well known and well publicized. You know, you had a common duct injury. Well, it may as well have been 10 because everybody knows about it.
yeah, it doesn't matter if you do something good or something bad, everybody knows. They don't know the facts. You can't get on the TV and radio and say, well, this is what happened. That, you know, it was adhesions or it was stuck or they had cancer with it. They don't understand. You might cut something. But
Now, you've mentioned before where you actually will bring family into the OR.
oh yeah, learned that from my trainers and way back when. I mean, very first time I was out in surgery, had one that had a bad radiation treatment for rectal colon cancer and had severe diverticular disease. And she was just leaking everywhere. Took her in and brought her husband in, dressed him up, said, look in here, look how bad this is. And he was a rancher farmer. He knew what the intestines looked like. He said, yeah, that's bad.
Yeah, apparently you all just cut animals open and you're pretty tired.
Right. But he knew, and of course she died, and of course the family in the town says, well, why did she die from? She only had cancer and she got over that. Well, they didn't know that, you know, they got infected, blew out her diverticular disease, all her anastomoses were leaking. That was just a bad situation, but it's always good to me if they would just bring the TV in on every case I do forever, or any surgeon. Hey, yeah, they could say, oh, that's bad. It's like watching TV. You know, you see 3,000 robots or cars or trucks blown up. Well, the same thing can happen in surgery.
We got a question. In these situations, is it hard to have a good relationship with the patient because maybe they've heard something bad, but you're also their only option for care? How does that impact treatment?
Well, that's always there.
Are you, before I came here, how long were you the only surgeon here?
Oh, it was a few years. We've had other surgeons come and go.
But you were on your own, you were the only
Yeah.
person here for a while, so yeah, I think you can uniquely answer that question.
And they always, the trouble is they think, can you handle it? And most of the time, I mean, they're simple, even gallbladder, appendix, or whatever, hysterectomy. I mean, things can happen, and they think, well, my mother 30 years ago, she bled out, and they gave her lots of blood, she never got over it, so they think the same thing is gonna happen. But most of the time, I mean, I try to keep everything simple. Even in my permits, it's simple. The state requires you to put, yeah, you're gonna have a cholecystectomy, but most people don't understand what's that. Then you say gallbladder, oh, okay. You gotta keep it simple, and I think everybody understands, even if something goes wrong. And when something does go wrong, like I said, I'll take the body part, or I'll bring them into surgery. And even if we have to send them off, it's just, you gotta let them try to understand what happened, whether we did a good job or a bad job.
I think yeah, that was something pretty eye-opening when you told me that, like, show them, like, get them in a bunny suit and show them just how bad it is in there, because if they don't see it with their own eyes, like, the people here, they're very much like, prove it, like, I need to see it. Yeah, the show.
Yeah,
They need to see it, and if you do that, then they don't. I think that the thing about this area and this type of patient population is they just don't want to feel like you're pulling a quick one on them. For the most part, they're really like genuine, honest, good people. They're not looking to, try to sue you or screw you over, but they also don't want to feel like you're screwing them over. So if you're really open and honest with them and transparent, I haven't run into problems. They seem to be pretty appreciative in that situation.
and you gotta remember, most people in Texas, they used to watch the TV, Red Duke. He'd come in the patient's room, he'd be in his shirt, blue jeans, cowboy hat, and maybe manure on his boots, coming in there and talking to the patient. So it's always been wide open, you just gotta let them understand, see everything.
The hard part for lay people outside medicine to understand is that you don't have to make a mistake to have a bad outcome. And particularly in a small town, if you do everything you know how to do properly and as accurately and correctly as you can, and still have a bad outcome, the blame always comes back to you. And after living in a place 37 years, it's impossible not to make at least a few people mad at you during the process.
Yeah.
We share call. There are 2 other primary care physicians that I work with. And to your question, yes, there have been occasions where I'm on call and somebody that really hates my guts comes in and has to be admitted to the hospital, and you just really don't want to be there. And the best way I know to manage it is just to be very transparent with them. Look, I know you don't like me and I understand, but the days of just being able to transfer you to another facility it's just not feasible anymore. So as soon as somebody comes back from holiday or weekend or whatever, I promise you, we can get you under somebody else's care. But in the meantime, just understand that I'm going to do the very best that I know how to, regardless of any kind of relationships we have outside the practice of medicine.
So I was going to ask about, we were talking about kids swallowing stuff, and I had asked what was the weirdest thing you'd ever seen a kid swallow, and you had been saying a lug nut.
Yeah, it was a little nut off the end of the screw. It was about the size of a nickel, probably.
What about you, Doc?
There was two. One was the open safety pin.
Oh,
That was a good trick. And the other person had a Bezor, and there was everything in there besides hair and vegetables. I mean, they must have ate everything. Open that up, and their stomach's about big as a little basketball, and
you took that
they
out.
had take this out, take that
That was pretty wild. That's gross. Did it smell bad?
out. No, no.
Any particularly unique cases? Like maybe weren't necessarily bad traumas, but just kind of unique.
Well, the only surgery one I still remember, 28-year-old, 30-year-old, went to different hospitals for the abdominal pain. And really nothing showed up, I guess, but came here in extremis and come to find out, of course, after the fact, did a lot of drugs and everything, but he ruptured his aorta right at the bifurcation with the iliacs, opened him up in there, and then there's just, a lot of times you think, well, I can clamp off the proximal aorta before the kidneys and down low, but it was just shred. There was nothing. That was the hardest one.
Did he end up?
Oh, he passed away on the table.
Wow. That is what about you, Dr.?
Not necessarily anything really jumps out as unique, but one problem that I do want to mention, somewhat unique, I suppose, to rural medicine, has to do with the issue of pain management.
Oh, yeah, that's a great.
So, oftentimes we, as, primary care, small doctor, small town, people will go to you with whatever pain issues they might have. And if it's an acute issue like a twisted ankle or broken foot, that's fine. It's fine. But more often than not, it's the chronic back pain or the chronic, whatever it might be, chronic pancreatitis, whatever. And so the challenge that we find ourselves in small rural America is that we recognize this exceeds the scope of our practice as far as starting or maintaining them on chronic narcotics of any nature. So our obligation is to send them to pain management, which we do.
Mhm.
At which time the pain management looks at it and says, your family doctor can do this for you, and I'll go back home. Which places us in a very awkward position with especially the attitudes of the state medical board toward primary care, writing extensive narcotic
So then
prescriptions. So,
yeah.
what do? It's we don't want to.
Or
We do what we have to get them to pain management, but they send them right back and you can take care of it.
Or you find where they were sent to pain management and they've been on opiates, like an elderly patient who's been on opiates for decades and they're on a high dose, and then pain management stopped them.
Yes.
And so now they're in a bad place. And, I feel like pain management has become all about stopping opiates. Like their whole prerogative is stopping everybody's opiates prescription. And I see them in here, and like for example, I just diagnosed a lady with anal cancer, and she's too frail to undergo chemo radiation, but she has a lot of pain. It's right there at the sphincter muscle, and I can't find somebody to treat her for her pain. And as a surgeon, I can't prescribe opiates long term, and my heart goes out to her. I don't know what to do for her. It's a really crappy situation.
It's almost got to put them on hospice totally to get it.
Yeah.
But I learned my lesson right out of residency. In residency, you got 100 people there watching them in the hospital. Well, going out to a small hospital, and then I do a D&C, and then I'm thinking, all right, we gave all this medicine here. I've got Demerol, Phenergan ordered, everything afterwards. She goes to her room and she goes apneic because they touch her and she moans, so they think she's in pain. She didn't wake up, so they give her another shot. So luckily, the internal medicine guy was on before I got there. de-intubated her, saved her, like a 40-year-old. We were doing the DNC. And so after that, I'll give the lowest dose. Everybody makes fun of me because I give pediatric doses. They can add to it, but I'm never going to have another one go at me for a DNC
Yeah.
or any case.
Well, and speaking
There's
of,
no reason.
speaking of DNC, that's a good topic for that, because in our line of work, we don't have OB-GYN in our area. So contraception emergencies fall on us often. Ectopics, miscarriages. Do either of you, with the new legislation, find yourself concerned about your license or being sued?
I don't think if you do the right thing, I mean, I don't do abortions or anything, never. And we just had one come in from another hospital because Dr. Roach then don't do deliveries anymore. And the placenta's hanging out. The ER doc's got his hand in there holding whatever body part. It's already dilated. Of course, the kid is deceased less than 20 weeks. And so what are we gonna do? We're not gonna sit there and pit her or whatever. We'll just take her to surgery, remove the fetus. And they'll look at that on the records, but, you know, I think you just have to look at every patient and do the right thing. That's all there is to it.
We've been talking about all the disadvantages of living in a rural community. Talk about one of the advantages. Everybody knows everybody, which may be good and may be bad. But in our community particularly, everybody knows who I am. Everybody knows what I stand for, and not going to put me in a position where I have to make those decisions because they already have a pretty good understanding about where my boundaries are with regard to my practice of medicine.
So yeah, that was one of the questions I was going to get to, is what are some of the best parts of this type of job?
Well, the good part is, you know, even if we do something here, and most of them are grateful and that they know the situation, and knowing me, and I'm gonna tell them, you know, the family comes in, well, don't tell them they got cancer, well, don't tell them that they blew out their colon, don't tell them this. I says, you need to go see another doctor. I said, they need to know, unless their mental capabilities don't understand that they're a human being, you've got to just be honest, and then they won't put you in that position like Dr. Roach says.
Yeah.
I probably shouldn't admit this publicly, but there are special favors. And I'll just give you an example. The HVAC guy, he always answers my phone calls first.
You get that AC
He gets-
fixed
yeah,
right
he gets that air
away.
conditioner fixed. We take care of his family. Of course, you know, we oftentimes do things above and beyond what's required through our clinic practice. They'll call us on weekend for
Yeah.
request of an antibiotic or refill of the medicine that got to get filled, or whatever the privilege need might be immediately. And of course, they remember those things and they appreciate it.
Yeah.
And they want to stay in good graces because of those.
You do feel
circumstances.
like you feel like an important member of the community.
Absolutely.
But you do have to, at the same time, you also have to kind of hold yourself to a higher standard. Seeing if there was a question. Yeah. Any advice for people, I'm sorry, I should have clarified that. So we're always trying to get like younger people to look at this and to get interested in going into oral surgery, and just in general for the younger people who are starting practice, you know, if you were looking back at yourself when you're first starting, back in the 1800s, Dr. Moses,
Thank you.
what advice would you give yourself?
Well, but you gotta look at today's, what's going on in the world and all the complicated stuff. And I think all the training places, they're training people, all right, you're just gonna take care of the belly or the gallbladders or appendix. You're not gonna take care of that broken arm or the tonsils or thyroid. It's becoming so specific. I think that's where the training's going, just from what I read. I could be wrong.
No, yeah, you're right.
And so that's why they want to be in the big centers, because, okay, they get in there, okay, oh my gosh, there's something going on with the pancreas or the uterus. Well, I got to close up. Well, no, you don't. There's somebody down the hall
Right.
that can take care of the problem. So that's what I say. But you got to know at least how, you got to use that mechanic type thinking. How can I get out of this in a small hospital till I get them sent somewhere else?
I always joke that we are the board question, right? Like, you're working at a small hospital, ortho's unavailable,
ETOS
yeah.
scenarios.
We are that scenario. We actually live it. So.
Right. I was luckily trained. I'd still be, I just like learning. I trained to do thyroids. My trainer loved doing thyroid. I did tonsils. And I learned it not only from family practice guys, but from ENT, pediatrician, different guys. And my gym training was at Fort Hood. We do like 10 tools, 5 hysterectomies a day. They don't do that anymore, I don't think. So that's the sad part, that's the hard part, trying to get somebody here that does a lot of things.
For the residents considering
Go ahead, Dora.
Hey, Rob, your question is, okay, for the residents considering rural surgery, how can anyone, not you, be reached for potential mentorship?
What to do before they get out of residency.
Rob, do you want contact info? Is that what you're asking? It says, how can anyone, not you, be reached for potential mentorship? Let's need a little clarification there, please.
As far as offering advice to somebody going into rural primary care, the one thing I would say would be just make sure you're prepared for the commitment that is required to do so. It is not an 8 to 5 job. It does not stop on Friday afternoon. Some of the best dermatology I've ever practiced has been in the grocery store.
At Walmart.
At Walmart.
Absolutely.
It is a commitment, particularly because everybody knows everybody. You get to know your patients on a much deeper and more intimate level. And so, yeah, you are available to them after hours. And you do have responsibility to the emergency room for being on call schedule. And sometimes you have sick people in the hospital and you just got to stay up there with them to get them sorted out a little bit better. So it is a huge commitment from a time standpoint. And if you're willing to make that commitment, it's incredibly fulfilling.
Yeah, it's very rewarding. The other thing I would say is the call is different. So when you're in a major city and you're maybe 1 in 7 call and you're on call, you are getting just murdered, Whereas you might be on call a lot more here, but sometimes it's rough, but for the most part, and you guys can back me up on this, it's not,
Right.
it's much slower, it's a much slower pace. I think it's a lot more relaxed, so you kind of take it at that. I mean, if you need to be off every night so that you can party, then it's probably not life for you, but, oh, I'll send out an email with contact information, Rob. So
What's
Yeah.
the-
I'll send an email after this webinar with contact information. The advice I would give to myself a million years ago when I started, I'm actually 70. You don't know it. I just age really well.
Good Botox.
Is I would tell myself to relax and not take everything so super seriously and be so stressed out. And I'm still working on that with my own mentor over here. You don't have to always be right, and you can let some things roll and it'll make you a lot happier and make things a lot easier. So I believe it is time to start wrapping up. I think Rob wants to say some things.
I think this obviously. Thank you so much. This is excellent webinar, and today I will say we've learned that the career in rural surgery is not only incredibly rewarding, but it has its unique challenges. And I hope you enjoy this webinar on rural surgery emergency. I have learned a lot. I would say thanks, special thanks to the moderator of this webinar, Dr. Samber, and Dr. Moses and Dr. Roach. You guys came with a wealth of experience, and um, some of your stories were quite touching, and I appreciate it. A special thanks to the planning team and the ITUS family. We hope our listeners will join us and become part of this great community by going to the website on the screen. It is www.fixonline.org. For the next webinar, watch our website. We'll be posting the date. It should be happening sometime in October. See you soon. Again, I'm your host, executive producer, Rob Amajoy.